but this should take about 7 minutes maybe in the clinic. Screen tests, those three. Okay, so we're doing what you kind of call the pretzel back in school, cross arm, and the crank. And we're looking for whether or not we're trying to rule in the shoulder girdle as a possible culprit here as far as those things go. Reproduction of symptoms. Passive mobility, we're just checking to see how well the glenohumeral joint moves without the scapula. Okay? We have the one little thing here with a couple different motions. Traction to see if we can improve motion for impingement. Elevation of the shoulder girdle to see if we can improve symptoms for a dural situation. Okay? Down into the quadrants, looking for how well the humeral head is centered and any arthrotic instability. Basically, this is a consistency of close packing test, taking it into the close pack position, various motions, scouring that particular joint to try and find any blips in that, see how well you're able to get into those positions, seeing if we have any particular crepitus or crunching of that joint as we try and get there. If we're having a hard time getting into this position from all kinds of directions, there's a pretty good chance that that joint at that point has become osteoarthrotic.
So the cluster of the osteoarthrotic joint is the quadrants. It may be some of our load and shift, and it may be, what else did you say?
For arthrotic stability?
Yeah.
Well, these are the ones. These are the
I
ones.
just want them clustered together.
Yeah, arthrotic stability. You shouldn't mistake that for anything else. This is the joint that's stiff, but still somehow feels unstable within the joint. The joint surfaces is what's starting to break down with this one, but the capsule around it is what's preventing you from getting into the closed pack position. Does that make sense? So we have stiff capsular tissue or paracapsular tissue limiting you to get into that closed pack position, but the joint surface itself is what's unhealthy, and that's what's giving us that crunching type of sound. Okay? And you may not just see these with people that are in their elderly years. You can see these with people post-traumatically if they're not treated. You can start to see these with people that have had, say, like a Hill-Sachs lesion, and the joint starts to break down because it doesn't get the nutrition it needs, okay? Because it blocks the synovial fluid from getting into the joint surface. That'll break down the joint surface real fast, okay? So once we're past that, that's going to give us a general idea. Do we need to go in and do our stability tests as far as ligamentous stress testing? We have 3 directions that we're looking at for that, okay? Anterior direction, we need to test the superior glenohumeral ligament, middle glenohumeral ligament, and the anterior band of the inferior glenohumeral ligament. Okay? That's all this is. This is the direction of the stress. When this is the direction of the stress, we still need to test those 3. And the difference being the posterior band. And then for posterior stress, we added that in with these, but that's just because those 4 tend to be clustered together because you can do them very quickly. And that's the one with the posterior shear. And that's where we're at right now. Does that clear anything up? Does anybody still have major questions about what we're doing with this stuff? Shoulder is very mobile, so stability is going to have a lot of different directions we have to take it. Okay. Onward. So coming from there, what we're going to do next is capsular tests. I'll write that down there. Okay, so we're checking for the integrity of the joint capsule. So come on up.